So hello everybody, we're live, I guess.
So thank you all for joining us again. So remember, this is a recurring webinar that we use pathology to sort of highlight the aspects of the product. So it is product centric or specific, to the product, not trying to sell you anything, but really to engage people that especially have the product, or some people that might be interested and have maybe seen the product, and really kind of an opportunity to see maybe how we might utilize it or implement it within practice. So this month's case, it's been a very interesting one to me. I see Matic is on here, so be gentle with the questions at the end if you have any, because my specialty is not prosthetics by any means, but I had a patient come in, and this is a patient that's in his early 60s, and he's experienced a lot of metabolic conditions throughout his life, really, and also doesn't live the healthiest lifestyle. So doesn't drink, but is a smoker. Nutritional intake is not the best. He's approximately 1.85 meters tall, but he's about, let's see, I'll do the math for you. So he's about 75 kilograms. So he's always struggled with his weight. And approximately 4 or 5 years ago, he was experiencing a lot of wounds in his lower extremities, and subsequently a lot of necrosis. His toes were literally falling off, when he wouldn't pay attention to it and he would take his socks off, he would realize the distal tufts, the end of his toes, were not attached. So seeked out medical care, and eventually had amputations. So he is a bilateral, so both limbs in the lower extremity below the knee loss. And so he's a bit of a case because he's got this metabolic syndrome, and he also is a bilateral amputation with prosthetics. The first time he entered the clinic, and I'm not treating him for that. I'm not a prosthetist, so I was treating him originally for back pain and for shoulder pain. In addition to, he was not on a consistent pattern of insulin, and up until about a year ago, he was using injections, but it was variable. And again, he's not really good at following a regimen. And so up until about a year ago, he was finally fitted for an insulin pump. So better regulation of his insulin. Even then, he had this very interesting delay. So after food consumption, even high carbohydrates and simple sugars, it would take hours before his blood glucose levels would rise. So he was always over insulin injected for the most part. So that's always been a bit of a challenge. And so we did a project here, my colleagues, with diabetic patients and evaluating gait patterns. And we know that even without neuropathy, the metabolic syndromes, and there's associations with uncontrolled glucose levels and the impact it has on gait patterns, which as a clinician or a scientist makes it interesting, but something that we can potentially use as practitioners. The other thing that this gentleman has had, and I'll share my screen. You can see the picture. The first, so the first time he came in, it was strange to me in that, so he's pretty equal in terms of where he had his amputations done. But the first time he came in to see me, he actually had 2 different brands of prosthetics. One of them was a hydraulic ankle. Another one was a spring-loaded ankle in terms of the dorsiflexion, plantar flexion mechanism. And I thought that was interesting because I felt like that might actually kind of throw off his gait pattern, which could subsequently create some issues as you go up the kinetic chain. And as we know, abnormal gait patterns can facilitate abnormal shoulder movement if you think about it separately, or vice versa. If you have a shoulder problem, we can detect abnormalities in your gait pattern because of that particular symmetry. And so was experiencing a lot of fitment issues, a lot of abrasions in the stump, and so that kind of told us he was not really at the right clinic being treated. Later on, ended up at a different clinic, and they've done a great job with the fitment. You can see that he's wearing the same prosthetic bilaterally, and it is a hydraulic, semi-flexible ankle to it as well, which I think made a big difference. So the first time he came in, I did not get a gait analysis on him. It was just an interesting situation, and in fact, I wasn't even sure that the Digital Pro was going to be able to pick it up. But moving forward, the second time he came in, I actually was able to capture an analysis, which I'll show you here in a moment. I also showed that the last time as well. But just some quick notes, and this is part of the things that dealing with prosthetics. And again, we have some people on here that are better experts on prosthetics than I, but we'll see that as his fitment is good symmetrically, and we'll see his gait pattern is also quite fairly symmetrical. And again, we'll talk about that. That's why we're actually going to be here. And so he does have, if you were to draw some lines, he does have a bit of a genu valgum to his stance position. And again, we'll talk about that a little bit moving forward, but it is very symmetrical. And so that has an impact, obviously, on some of his gait patterns. And the reason I bring that up is because those of us that maybe are not, the experts here, that if we were to get involved in some gait analysis, there are some things that we certainly need to take into consideration. And I am very fortunate to work with a very large and diverse group of practitioners that assist me in that process. Here's the interface, and this is the specific patient. So when you pull up your patient profile, you can look at a dashboard and it shows your latest activities. If you're not seeing all of your activities, you can click on the practitioner analysis, and that will allow you to look at all of the activities. And patient file, that shows us the relative information regarding the patient, and you can make changes as we go along. Now, remember that when you do make some of those changes, it'll impact, that the data calculations. And so that's, something to think about. Like if he were to actually, add weight and I were to change that, keep that in mind, how that changes. So with that in mind, if there are dramatic, demographic changes to your patients, you may want to consider sort of creating a secondary file. So for example, after he got his blood glucose levels on task, and started gaining weight, which he didn't, but if he did, then I might want to change and create a secondary profile, just so what we calculate moving forward doesn't have a negative impact on what he really was when we took some of those other analyses, if that makes sense. Okay, so just something to add. And remember, you can add other information in here as well at any moment in time. And then when we look at the analysis, of course, we can also add some data in with that. We'll come to the evolution here in a moment, but just to show that what all these tabs actually mean. Home screen, I'm not going to go over that. Equipment, that just shows you what you have available, because you can have I have 4 different accounts. So I have different sensors attached to each one. Settings, you can make changes. Obviously, I'm in the United States, so we're going to use English Imperial. Those of you in other countries, pretty much every other country is going to use the metric system. I will say, to knock the United States, that at least in research, we do use the metric system, by the way. But so you can, create some of those settings. So back to my patient here. So I'm going to click on this first one. So this was almost 6 months ago to the day. So this was fairly new after he had received his new prosthetics, and he hadn't been uh, getting his blood glucose levels. He just was working in a new metabolic guidance practitioner that he was working with to get his blood glucose levels online, and his insulin in particular. And so um, just kind of figuring that out. Now, you can do this free walking, so overground in a clinic. I do that more than I use a treadmill, but I do use a treadmill because sometimes if I want to control the speed, then we're going to do that. And the problem with the treadmill is, especially in this case, remember, when you're overground walking, you're going to use your hip extensors, to initiate and pull yourself over that point of contact. Whereas a treadmill, you put your foot down on the belt and it pulls it forward, pulls it backwards for you. And so that changes the dynamic a little bit. But think about, like in this case, not having active plantar flexors and the potential impact on that. And a lot of people that don't walk on treadmills regularly can experience some potential balance issues. So this guy was he was not well balanced to begin with. Like I said, he was transitioning to these new limbs, these new prosthetics, and was still experiencing a lot of variability in his insulin levels and his glucose levels. And so he was not very steady at all. And I didn't know if you saw in the picture. So I don't have a harness system because this is not, something typical for me. But so I didn't want to push him too hard, but we found him most comfortable at approximately 1.3 miles per hour. He couldn't go any faster, which I'm not gonna push him, when it comes to that. So you can see that his speed is actually really low, and that is really low for his particular demographic, his age, his gender, and his height. So that's why it shows in the red. So remember, the AI aspect of this platform is in the red means they're 2 standard deviations or more from normative values, and amber is 1, and green is within 1 standard deviation or less. So we also see that his cadence is low, and obviously stride length is part of this calculation with regards to speed. It's a product. Speed is a product of stride length and cadence. And so he's got a really short stride length, as we'll see here in a moment. But that's why his cadence is also really, really low. So then we look at the walking profile, and for his height, we probably want to see about almost double, not quite, but so he has a really, really short stride length. And we see that it's very excessive on the stance phase, but that makes sense. When you walk slower, you're going to have an excessive stance phase. But we do see that he's at least symmetrical, and that's kind of important as well when we think about the performance aspect and the impact that it might have on the kinetic chain. And so that's actually a positive thing. But if we want to dig a little deeper, you click on the advanced. And the AI aspect of this spatial temporal parameter presentation is good because it not only tells us if they're outside normal limits, but it tells us which leg, and it tells us which direction. Is it high or is it low? So we see the stride duration is very, very long based on the length, right? And the stride length is obviously very, very low. His swing time relative to his stride is, within that 1 standard deviation. And so that's where it helps to sort of give us some information. Well, at least based on having a really short stride length, that, his swing time is in there. Stance time obviously is, as we saw, with that high percentage rate, but in general, his stance time is really, really long relative to what would be considered normal. So these are the two characteristics I find, very interesting. He's a great patient. He understands that I am a clinician, but I'm also a scientist, and so I take interest in not people's problems, but their conditions per se, and how we can, as a community, hopefully do a better job at taking care of people. So it's interesting when you look at the gait line, and of course, remember our gait line is a center of pressure measure, but we don't use pressure sensors. So we use an algorithm to relate the movement or the position of the foot relative to ground contact and center of pressure. And so it's a little bit more qualitative. And that's why you see these lines, right? And these lines and the orientation of each dot. So heel strike, toe down, heel lift, and then in the toe off, right? And so we see, and it's pretty obvious, he's very medially in ground contact and throughout the entire transition of ground contact. Now, the good news is he's very symmetrical. And so why do I keep saying that? Well, it means that up the kinetic chain, at least the forces, ground reaction forces, dynamic forces, they're the same. And so that at least limits the amount of, rotation or torsional forces that, we might see, especially on the spine. And the other thing I did not mention is he has a his left hip has been replaced. His right hip, he needs replacing, and so we'll get into that here in a moment. But we do see he's very symmetrical. All right, so we see that once he heel strikes, he his limitation is a little bit longer on that left, and it's definitely shorter on that right. So the control factor is a little bit different, but it's not that much different. So I wouldn't get hung up on gait line, especially not actually using pressure sensors. We're using time and sort of foot orientation. And foot orientation makes a difference because maybe that transition is really short because of how he is heel striking. But again, I'm actually okay with this, and I'll talk about this a little bit more as we get into the next section. But we see that in foot flat position is where he spends most of his time, right? And let's think about this for a second, where he does not have active dorsiflexors that can create eccentric loading as he's going into heel strike, right? And so it's going to go down, and it's going to go down relatively quickly, and it's going to stay there until he initiates that toe off motion, typically as a result of hip and knee action that creates the ankle angulation effect that initiates, the plantar flexion influence that we have on that prosthetic, which, and again, I'm not the expert on prosthetics, but I was actually speaking, and we're working with one in particular, but that that position, and of course the rate of change in that influences the engagement of some of those mechanisms associated with that. And I'm going to come back to that in a second too. And that's actually what I also find a little bit fascinating, if you ask me. But and then we see, he transitions into toe off, right? So he's very much engaged on the inner aspect, and you can see it in the wear pattern of the shoe. I should have taken a picture, but I didn't. Especially in the follow up. So he's getting new footwear, and this was another thing that he experienced, was he had a lot of difficulties finding footwear because footwear changes, and if you've been following us, that we've done a couple webinars on the impact of footwear. on walking gait as well as running gait. And it's actually the same thing here. And that's one of the projects we've been working on with a manufacturer in prosthetics, is that sort of impact, and being able to measure that. If we look over here at the propulsion rate, so that's a ratio between plantar flexing and hip flexing going into the swing phase. So it's after that toe off effect. And what this does for us is it's an algorithm that uses an acceleration or and velocity into the swing phase. And from that, we get a calculation. And so we see it's in red here, which again, in our system signifies that, like I said, it's greater than 2 standard deviations. Now, there's a couple ways that this is calculated, and this is just our way. We didn't make it up, but we're using, at least a standard within the industry. Now, I mentioned earlier that I was curious whether or not I was even going to get it, to get the analysis, and the reason is we found in past history with other practitioners in particular, when the ankle mortise was fused, right? People that have had certain procedures and they don't have motion in the sagittal plane, the system, it would engage the firewall and you would get an error. But he seems to have just enough mobility in that plane that it actually worked, which was fantastic. So what's interesting again is this was really good at capturing that at 1.4 miles per hour. That ankle system was not engaging a lot, because you can see that he's predominantly using hip flexors. And that also makes sense because he doesn't have, an active plantar flexor mechanism anyway. So obviously he has to rely on the prosthetic device in and of itself. So those devices, and again, working with the manufacturer, coming from them, not my opinion or knowledge base per se, is that speed impacts those, and that they try and match it a little bit more with the patient. So we see that at his speed, it's actually not really engaging, and that can affect obviously the efficiency. So he works really, really hard, and I always watch him. I'm actually next to the window where I can see people walking up to the office, and I always like to watch people walk. Sort of a funny example. I had a new patient who a few weeks ago came in, injured his lower back, very fit individual in his early 60s as well, was preparing for about 100-kilometer hike in the Grand Canyon. And he was just, in a lot of pain. And so anyway, the next time I saw him come in, I noticed he stopped halfway, bent over to tie his shoes, and he walked in, and I said, "How you doing?" And he's like, "I don't know. I think I'm a little better." I said, "Well, you seem a lot better because now you can bend over and tie your shoes, which you couldn't do before." So always good to, keep eyes on your patients. So let's move to the details view. So anyway, so this gentleman, his walking is very labored. And for a couple of reasons. One, he's wearing, some prosthetics, although I've seen a lot of people that, quite able-bodied, moving like able-bodied. But again, we're dealing with someone with severely uncontrolled insulin and blood glucose levels. So let's look at, this phase right here. And this is probably not surprising to any of you that obviously use the system. You can see that he stays very much on that medial side, and that's just the way, his ankles are oriented, based on his fitment for his devices. So I was actually consulting with a prosthetist, um, and so because my questions were like, okay, I'm fortunate, like I said, enough to have this diverse, but imagine, and I asked them this flat out. I said, what do you think would happen if I were to say, oh my, he needs orthotics? and I'll show you something in a second here anyway. And I fit him with orthotics, and he said, well, he's like, that really will impact his socket. He's like, because there's a lot of, changes to the mechanisms and the fitment that matter, when it comes to that. And I said, well, that's important, for people to understand, is that, don't just go, adding heel lifts and things like that if you're not, that prosthetist and that, and have at least that level of expertise to understand, what that fitment looks like. Because again, if a typical, practitioner like myself looks at this, they would say, oh, he needs orthotics, and I would fit him for orthotics. That could actually have a really negative impact on his gait pattern. As I mentioned earlier, getting these notifications. As I mentioned earlier, that he is fairly symmetrical, and that's kind of important. So we do see that, and I've commented on this in the past as well, that when you look at, you put the cursor over the dot, it tells you the actual the mean, and then the minutes are actually standard deviations. So that gives you some variability to look at. So he has very low variability on that left side, right? And we see that that's very consistent with people that typically have lost some level of mechanisms associated with proprioception or changes to normal gait patterns. So this is normal for that person. He's got a little bit of variability here, which is actually good in the sense that, they can modify their behavior pattern relative to the ground surface. So we like to see this a little bit more so. If it's really wide, it means they're outside of that standard deviation, and they're either in a new experience or a new pain, a new injury, and that's kind of how we use that information, to show people. In fact, I was communicating with another practitioner using devices that they use to correct gait, and it's stimulatory. And so what they do is they create a perturbation that throws them off. So we would see large variability, and if they remained with that same stimulus, they could accommodate to it, and then the variability would reduce. And then with our system, they could say, oh, so they're back to, now we can go up to that next level. And that's actually another way to, potentially use that. So yeah, we absolutely do see some abnormalities with regards to his positioning, but in his case, that's, believe it or not, on the normal side. Now let's look at the foot progression angle and the circumduction. So he's within normal for both of these, right? So we see a normal Western population, asymptomatic, has, in 2 standard deviations, is -2 to approximately +14. I think 14's on the outskirts, but in any event, that's what the data shows us. And so we see that he's definitely normal. So the other thing I consider is he symmetrical? And so he's not exactly symmetrical, but it's not that far off. And again, depending on how much data you're collecting, I actually did have him walk on the treadmill for a period of time first so he could accommodate to it. And despite the fact that he wasn't overly comfortable, um, he did pretty well. And so he's within normal, and I don't really see this as a problem. His new hip, and actually it's been several years, so he's definitely accommodated to that. This looks pretty good to me. What we see here at this 8.3, right? So not quite 2 times, but almost 2 times. But what I want you to look at here is this is his circumduction. So a normal gait pattern, right? They're going to outswing, because that's part of clearance, ground clearance, and that's one of the strategies that we use, along with dorsiflexion, along with knee flexion, along with hip flexion, right? So remember, he does have a knee, so he does have a functional knee because he's a below the knee amputation, so he does have that capacity. But this is his bad hip. So when you see -7, so he's 3/4 of an inch, right? Which is what, maybe a little over 2 centimeters. he's actually breaking the midline. So his hip is coming in and then it's swinging out. And that's due to the problem that he's having in that hip joint, right? And so that's the strategy that he's using, because when he outswings, a couple things. One is it's uncomfortable for him. He experiences some pain with that. Two, his weakness, his muscularity is not very good. So he doesn't have good abductors. And so it's almost like he just kind of swings that leg through. And as you can imagine, the weight is going to pull it more inside than it is on the outside. So definitely something to take into consideration, and we'll have to see if it actually changes. So then we look at the steppage and the clearance. In the steppage and the clearance, we see, his angles are going to be off. And again, that's actually normal. So if you recall, in the propulsion rate, he really wasn't engaging his dorsiflexor mechanism in the prosthetic. So he was actually a really high angle, and that's why there's so much hip engagement. And so I would expect that, and they're pretty close between the two, but that's why you see that in red. And then he's walking so slow, it's almost like a shuffling or fenestrating gait. So really low on that right side, still kind of low on that left side. And I made a change. I think in the next profile, we'll see his clearance was actually normal. He's about 1 inch off the ground. So he's doing a good job at compensating for the lacking of dorsiflexors, right? So he doesn't slap his feet down either, which is really, really good. So this is, I don't know, kind of fun. So let's click and see what orthotics would tell us. So it does suggest some corrections. And so on that left side, especially on that heel strike, and the reason our algorithm also is predicting the result of adding a heel strike correction and its influence throughout the rest of the trajectory in that foot ground contact position. A little bit more on that right side to basically keep him in that trajectory and further assist with that toe off position. Again, I wouldn't do this because of his situation wearing the prosthetics. If this was a person without prosthetics, I probably would want to correct that, again, considering what else is going on with that particular person, if they're experiencing some pain and things. But to see the fact that, very, very symmetrical, I would be careful. I would be cautious in making corrections in people that are very, very symmetrical when, let's face it, gait is a challenging thing to say that, there's one perfect gait pattern. Okay. So let's go to the second one. And so this was actually also done recently. So that first one I just showed you was almost exactly 6 months ago. So kind of interesting. He's actually a normal patient of a colleague of mine, so I don't see him on a regular basis. So I had actually asked him to come in specifically for this purpose and get tested, and I treated him my way as well, which he tends to like. But so again, symmetry is still good. We see he's improving his cadence, but this is really important. So we're seeing, 1.8. I actually had him up to 2.0 miles per hour, and he was doing really well. I did not having a harness or protective mechanism. I just wanted to be cautious. And so we went from 1.4 to 1.8 miles per hour, which may not seem like a lot to most of us, but that's actually pretty significant. He, like I said, could walk over 2.0 miles per hour. So his speed was actually approaching normal. Now, again, this was on a treadmill. So when he overground walks, he can walk faster. And that's why if I were to redo this, I would have him walk comfortably over ground instead. But again, this was more of a purpose of science, right? And so overground walking could be interesting. Another note, so he had recently come back from a cruise in Alaska. So Alaska is up by British Columbia, so it's the upper Northwest. And and he goes out hiking, and he works very active. And so he can move a little bit faster. And I asked him how he does with that, and he goes, I just lean forward and let it rip. Meaning he lets himself almost get off balance, and it helps him move forward. And I said, just dude, be careful about falling and whatnot. He's there's plenty of people around me. He also tried alpine skiing this year. I forgot to mention that was one of his goals when I saw him last time. The problem was he did not want to do it the normal way. He wanted to do it his way. And by normal way, I meant, having certain corrections. He doesn't have lower limbs, and so it didn't work out very well. So he didn't have really good control. But anyway, he tried. So here's some of the differences. We see his stride length is increased by, over 10, about 10 centimeters or so. And that's expected. He is walking faster. We see his stance time is reduced a little bit. We do see a little bit of asymmetry here. So if I quizzed you, do you remember which hip was replaced and which hip needs to be replaced? Right? So he's still lagging. And that's why I like using, sometimes in the same session, 2 different speeds, because adding a dual task or an increased stressor, either cognitive or, and we did a webinar on this in the past as well, either a cognitive or a physical stress, it helps us, sort of tease out some of the things that's going on. And it identifies more so that, that other hip is definitely lagging. But basically very similar characteristics as we saw before. But we see that his stride duration is approaching a little bit better. His stride length is still on the very short end. But again, I forced him to walk a little bit lower. He did have the capacity to walk faster. And so we see that his foot trajectory is the same for the most part. And he's walking a little bit faster, but the numbers are actually quite similar. And I'll show you the evolution here in a second, but exactly the same. And that's actually not a bad thing. So he's being consistent in his walking pattern. He's able to walk faster. And what we do see as a result of that, it's more efficient. So if you remember these numbers from the previous, I think we were at like 22 and 19%. So it's coming down dramatically. We almost cut it in half as a result of that, which is, again, a good thing, because now he's capitalizing. He's able to engage the mechanisms in his prosthetics, and that makes it more efficient. And that's important, especially for endurance and things like that, he doesn't get overly tired. So as you can imagine, these are also going to look very similar, but again, very symmetrical. And that's one thing I'm looking for, especially in conditions that there's limitations in what we can do. Patients with cerebral palsy, what we're looking for is limiting, the progression of abnormalities in some of these cases. And so we're definitely seeing that, with this patient here. We see, again, fairly symmetrical on the foot progression angle. He's still crossing that midline because he still has that particular hip problem, right? And so 1.7 degrees versus his out toeing on the previous was, I believe, 8.2 or 8.3 degrees. That doesn't matter to me a whole lot. He's still at least in the same direction. It's a little bit less. And again, that may have happened even if we tested him 6 months ago, just at the same speed, but he couldn't. And that was, again, related to, we're finally under control more so. So he's been 6 months now with his new insulin pump, and his blood glucose levels and his insulin levels are fairly normalized. So even subjectively, he says, he experiences less bouts of unsteadiness. He can walk faster. He can do more work. He does a lot of carpentry work. And so he's able to do that and feel more comfortable and safer, which is a good thing. We see that his angulations, again, are very, very similar, and something that I would expect. Because he's walking a little bit faster, we see these angles are a little bit larger. and approaching closer to normal, right? And so we would definitely, look for something in the 15 or above if we could get to that. And we may see that, at his particular walking speed. So we do have this feature called the evolution. So that allows us to basically take multiple tests and look at it over the time course. So we see that his symmetry, and again, you need to consider the data. So his symmetry was almost 99%. He's at 97%. So perfectly normal. I'm okay with that. His cadence actually improved, so we can see that graphically real easily. And by the way, you can see the global numbers is from over the time. So we see that he's improved by 38%. His stride length, again, dramatic increase in those two. His stance time is reducing. His swing time is reducing. All those things that we would expect to actually see. Propulsion rate, yes. So we were down here at 22 and 19%, and then we improved up to 10 to 12%. That's a component of also walking faster because it engages those hydraulic, plantar flexors as is explained to me. We can look at the advance, the attack angles, the clearance as well. So again, just looking at a lot of positive changes. Is he away from the green? He still is, but again, he's probably never going to get there just because of his situation. But what it does is it still gives us a target that we can use, and eventually we are going to level off. Like there's only so much progression that we can make given his situation, and then we're just looking at making sure he's not regressing and making sure that we're maximizing whatever treatment. So for someone like him too, think about looking at like a fall risk profile or something, and another way to kind of use the data because, he's at that age. He's overall has high mobility, but again, his health is such that I would be concerned. He hasn't had a bone mineral density test, but given his body mass and things, I think there's a risk of fall here. And that's another thing I talk a lot with people like in this situation is, that's a consideration in and of itself to make sure that, we're monitoring that because as you all know, a fall is a really bad situation moving forward.
I have added the education email, so you can reach us on this email if you want. And if you have any questions for Chris, please do not hesitate. And if you have any special requests for future webinars, a certain topic that you like, or something you would want us to explore further, or if you have taken a measurement, an analysis, and you would like to share it with Chris to go over it in a future webinar, please feel free to share it. Well, let's see. Anybody has any questions? Apparently no questions, Chris, so far. Our group today is a small group. Anyway.
Even Ramsey?
Even Ramsey did not ask anything.
There he is. Thank you, bud.
Okay, it seems there is one question. So Ramsey is here actually. So he says, how much do you think changes in prosthetic development will influence changes in gait rather than patient-centered rehab?
That's a really good question. And so, again, I've been very fortunate to work with this particular individual. He teaches in a master's degree program in prosthetics. And also he teaches in a doctoral program in physiotherapy. And one of the things that we're trying to kind of figure out, because we got into this whole sort of discussion, and this particular patient was of interest to me because I after I took the first initial analysis, I said, hey buddy, by the way, I'm happy to share any data. And we don't actually see a lot of gait analytics. It's observational, it's visual, and you can certainly gather from that. To be honest with you, I think that both of them have dramatic influences. The mechanisms, the devices that are being, you know, produced today, they've got microprocessors in them. And what's interesting is imagine, because our system can actually give that feedback. I mean, you guys haven't seen it yet. We're able to capture angulation at the ankle, the knee, and the hip, as well as obviously the foot orientation, and potentially using that API to feed systems, the microprocessors, to actually make those corrections, which is pretty amazing. But then there's, and he shared this with me. He's like, you know, there's a lot of things like the physical therapist, when he's like, I was making adjustments to the device, whereas the physiotherapist was like making adjustments to their regiment, their training program, and how they could actually correct some of those. So I think it's really going to be a blend of both of these, and I think it could be amazing, you know, to help with patients. And I think at certain levels there's some unique opportunity for practitioners to work together. I think there's a lot of separation. I have another, he's not a patient yet, but I've been working with treating. He's a recent amputation below the knee, and I do other modalities. I'm working on laser with him because laser can also reduce obviously infection and the phantom limb pain situation. So we're trying to keep that from happening altogether. But in combining, you know, these two worlds, there is an event coming up for those of you interested. But there's an event coming up. I think it's the first time ever the U.S. Olympic Committee is going to be hosting the first ever Paralympian sports medicine conference next year. I was trying to connect with some folks in that prosthetic space. I couldn't. Again, it's just weird that there's not really that interest in actually collecting the data. So I don't know, Ramsey, 50-50. I mean, I think there's opportunity, you know, in both directions for sure, because like this particular patient, he lacks so much posterior chain muscularity. And if he was my patient, man, we would be working on that. I think it would really improve his efficiency in certainly in push off from the hip. I think we could also do some correction with the abduction moment as he's going through circumduction. So I absolutely, it could definitely have some impact on the gait. But I would need to also work with the folks, you know, in justifying, you know, some of those changes. Like I wouldn't want to put over stress on the socket and things like that. So I think there's a lot of unique opportunity to coordinate and work together.
Thank you, everybody, for joining us today. We will let you know if we're gonna. I mean, are we gonna have a webinar, Chris, in July, or we skip till September?
So yeah, we thought about that. I like the live and the interaction. So what we're going to do, folks, is we're going to use a previous case that we've talked about before, and I'll present it again, but I'll present it live.
Okay, so we will do a session in July. It will be the third Tuesday in the month, like what we're doing now. And we will share with you by email an invite to register for the webinar. Looking forward to seeing you, but we will be skipping August for your information and coming back in September.
Yeah.
So don't hesitate if you have any questions or if there's anything you would like to share. We're here for that. You have the email in the chat, and looking forward to hearing from you. We wish you a good evening for the ones who are at evening time, and a good day for the rest, like Chris. Yes. See you later. Thank you so much. Thank you, Chris.
Thank you all. Take
Bye.
care. Thank you, Rana.